I'm going to do the poll and try to talk at the same time, which is for me. It's
John's going to walk and talk at the same time.
yeah, it's a bit difficult, but I'll try. Yeah, Lorrie is a member of the National Council, which I was a member actually, and then somebody else has taken over representing our group. What's happened since COVID? It's really quite neat, actually. Some of the things that have been going on. We meet once a month, the National Council, and we represent groups right across Canada. And that's how I met Lorrie. Lorrie's a registered nurse, retired. She's done all kinds of things. Worked in palliative care, worked with women's health. The list goes on and on and on. So name it. Have you ever worked in an emergency ward? Have you worked at emergency urge, as they call it?
Well, our son and our daughter are both nurses. So our son is actually a trauma room nurse. So yeah, they're 4th generation nurses.
Yeah, there you go.
Yeah.
Yeah. So anyway, that's how I met Lorrie. And I don't know, I emailed Lorrie one day and I said, we're always looking for presenters for our group. And I asked Lorrie if she knew anybody. And she said, well, I could do it. So this is how it's gone. I'm just doing, okay, now I have external beam radiation and
HDR.
Yeah, thanks, Neil. What does that mean?
HDR is the new high something radiation.
Yeah.
High density radiation.
Something like that, yeah.
Okay.
If you did it in the last year, pretty much in Montreal, it's pretty much HDR.
Okay, probably that's me.
Is that the one that they do over? There's one that they do over a period of 5 days, and then another new one that they do over a period of 28 days. And they're always changing around with clinical studies. So I always find it difficult to kind of keep track of the new studies. So there's several out there.
Okay, I finished my my poll.
So some people, I'm getting some messages, or some people have does not apply. Sorry, no, just pick one. If it doesn't let you skip it, there's limitations on how the polls are done in Zoom. So yeah. Just if none of them apply, just pick one randomly.
Just pick what applies to yourself.
Or if you've made a mistake about which one you clicked on, just click it again and it'll unclick itself or untick.
The funny thing is it doesn't let me do it. I can't answer the poll.
Because you're the issuer of the poll, I think.
Yeah, I guess.
Yeah.
Okay.
If you can't select one of the options, it won't let you submit the poll.
Oh, darn it.
Right. So just pick something for that one question. Which question is it?
The last two. There's no answer that applies.
So you didn't have any treatment at all, you mean?
No radiation, no ADT, whatever that is. So I can't answer those questions because there's did not do option.
So just do external non-HDR.
Yeah.
Yes. Similarly, I never had any prostatectomy because I had radiation treatment because my prostate cancer was advanced into the vesicule.
Yeah.
Okay, so we all learned something new now. So I have to.
Yeah.
I just put other.
Yeah, just put other. Yeah.
Okay.
Yeah, it's true. If you had surgery, if you didn't have surgery, pick other. I needed other on option 3 and 4. Okay.
Mm-hmm. Yes.
It's just to give us an
well,
idea. Yeah.
Okay.
But we can discuss the particulars throughout the presentation.
Yeah, it's just not going to make any sense if I click any of these options.
Yeah.
And I can't submit either.
We're not giving the government statistics here.
No.
Well,
our government doesn't care.
It won't make sense to you either.
That's okay. We'll figure it out.
Just before we start, who heard about this meeting through the ad in the Gazette newspaper? Just put your hand up and we'll just count. We'll count the people. I don't see any hands.
Well,
I
Mike,
see
we already
one,
know.
I see Mike. Oh, I see one other. Mike and I think we got two people, eh? Yeah, okay. We're always wondering about putting that in the Gazette or in the Suburban because it costs us quite a bit of money. And sometimes we're wondering, okay, is this worthwhile? So that's why I'm asking. My name is John Warren. I'm Vice President of the local prostate support group in Montreal. I like to welcome you here tonight. Couple of things we want to stress is that we're not doctors. We're not giving out medical advice. So if you want to get real medical advice, see your doctor, see your GP or urologist. The other thing we want to talk about is that this is a safe room, safe virtual room. What is said and done in the, well, not done, but said in this room stays in this room. We want to have a candid conversation about prostate cancer.
Sorry, I have to interject there. John, we are recording it.
Okay, but you're going to, okay, I don't know what we're going to do about that.
No, we like the other groups, we do record the speaker part.
Okay,
And when we have the Q&A, we stop the recording.
Yes.
okay, good point. Okay,
The,
so
for those who just sorry, for those who just joined, if you're filling out the poll, first of all, it's anonymous, so we don't know who's filling out what questions. So you don't have to worry about privacy there. And we realized that if you did one or the other, so you have to if you did radiation for the surgery, just pick other, and if you did surgery, then for the radiation, do external non-HDR and non-steroidal, or just pick something at random. It's not a scientific survey. It's just to give our speaker an idea of the proportion of people who did surgery versus radiation and which types of treatments.
okay, Lorrie, I think you could probably begin your presentation.
Okay, so I'm going to end the poll now.
Okay, and when we'll take a quick look at that, please. Okay.
Can you see the
Majority
poll?
Yes, I can. And I'll just bring it up. Robotic.
Does it let you scroll, or do I have to scroll?
Yes, it does.
Okay.
All right, I'm going to close it. And
Can everybody see the poll?
Yeah, I can. Yeah.
yep.
Okay.
If you scroll through it, then we'll all have an idea of what we're going to discuss in that. All right.
Yeah, so a lot of people had prostatectomies and radiation. A little bit more radiation versus prostate. You know, we should have also asked is the age range, because
Yeah.
as you get older, you're less likely to be a candidate for surgery and more for radiation, right?
Yeah. So that's on the learning curve for us, Neil.
Yeah. So we know for the next time.
Well,
we're gonna have you. We're gonna have you every other month. You realize
that? Okay. All right. Well, you're going to keep me busy. Good evening, everyone. And we kind of had a quick introductory and a bit of a discussion, and we kind of know where we're at. And my name is Lorrie Harrison. And as Joanne said, yes, I am a retired nurse. I also have a few, I'm an undergraduate of an adult educator as well, educator and trainer. So I did go to university for that as well. And plus, I am well versed in the clinical. I think I've had at least 7 different clinical areas where I've worked. So yes, I'm well versed in many little things. Not a master at any, just well versed. First off, I am in Regina, so I would like to acknowledge that I'm presenting in Treaty 4 territory and acknowledge the fact that we all share and are respectful of those that came before us. Okay. Now, let's get into that. Now, this is my personal professional disclosure, and I always like to use this. I always want people to have an understanding of where you know, I want to be straightforward and open and transparent. So I remain within good standing with the College of Nursing. Therefore, I signed my name as a retired RN, but I still pay my dues for my registration. So I still have a little in there. I already told you about my adults, and I am an undergraduate with that. I've retired after 40 years from the Regina Coquille Health Region, and that's part of the Saskatchewan Health Authority. And I was a regional educator. That means I was responsible for Southern Saskatchewan for educating and orientating nurses, and I did some teaching in the College of Medicine and the College of Nursing as well. So yeah, I'm well versed with that as well. I presently sit, as John said, as a Regina Board of Director, and I represent Saskatchewan on the Prostate Cancer Support Canada National Council. I do not have any ties to any big farm or any big corporations or anything, so I'm a freebie. Now, a lot of people kind of wonder, like, why the heck did a woman want to start, you know, get into prostate cancer? What the heck's behind that? And first off, it was when my husband was diagnosed with prostate cancer. And as a nurse, it's, you know, you want to get as much information as you possibly can. And I thought, okay, well, Boyd was diagnosed with this in 2019. Go to Prostate Cancer Regina and get some information. And lo and behold, we started up with them. And that's how it was back as Prostate Cancer PCCN, I believe, back then. And now it's changed to PCSC. Boyd experienced, my husband experienced some barriers to his care, and especially aftercare. And the barriers he experienced was pelvic floor physiotherapy. And for those of you that have had it, we can discuss it throughout the presentation as well. But what we found for my husband was it was very effective for his urinary incontinence and also for ED problems. So yes, it was very beneficial, but it wasn't covered in Regina. Boyd had to pay for it out of pocket. Whereas in Saskatoon, it was covered by the Saskatchewan Health Authority. So like, why is that? You know, it's all the same province. It's all the same health authority. Why in one city you have to pay, or actually Southern Saskatchewan you have to pay out of pocket, and in Northern Saskatchewan, north in Saskatoon, you don't. So that began our business of trying to lobby and get consistent standards of care within Saskatchewan. Also, another thing, Boyd considers himself very lucky, and I am too. I love my man. We've been together for 47 years, and I wanted to continue to make sure I had him around with me. So we wanted to start promoting awareness of early diagnosis and treatment. And I'll address that throughout the presentation as well. And for us, Boyd's cancer, we found out, like we just focused on his treatment. His cancer was very aggressive, we found out. And we were very lucky that it was well encapsulated and that we could get it all. And that's my boys, plus one girl. The puppy is a girl. So, and we did this for our grandsons. You know, as well as I do, that prostate cancer, it does follow genetic links. And we have 4 grandsons, and we want to make sure that our grandsons are cared for in the future. When Boyd and I are no longer here, I want to make sure my boys are cared for, and they're treated fairly and equitably. Okay, now our journey. And believe it or not, that one picture was of Boyd, and a friend of ours is a photographer in Las Vegas. And we were doing a fundraiser, and I call it the yin and yang, because, you know, we kind of mesh, and that was just us goofing around, but we wanted to make sure that we had a good sense of ourselves before Boyd went into surgery. And that was our way of you know, coming closer. And the other picture was a Movember picture, and Boyd was interviewed by Movember in regards to his journey with prostate cancer. Now, as I mentioned, we've been married for 47 years, and approximately, like I said, we're very, Boyd and I are very, we're very close. And about 20 or in 2000, they thought I had cancer. Over 13 months, I had 3 radical abdominal surgeries. And every time the doctors kept going in, they kept saying, yeah, Lorrie, I think this one's cancer. Okay, boy, I'm laying on the table, the diagnostic table, and Boyd and I are sitting in the room, and we have 3 doctors in the corner looking at my diagnostic films and my pictures, and yep, I think this one's cancer. No, I don't think this one is. And that wears on you. And I thought myself too, oh my God, like, you know, this is hard for me to take. What is it like for my husband to take? So that kind of laid our baseline, like we are going to live our life to the fullest. And that kind of that was 25 years ago about. And yeah, and we're here and now. And then Boyd's diagnosis with prostate cancer. He was there for me because I basically had a surgical castration. Like I was neutered. And I decided that I was going to be there for him. And no matter what, whatever his decision was, I was there for him. He was my partner. He was my love of my life. And I want to make sure that he had the best support he could have. And I'll just go to the next one. Now, also, I just wanted to say, now, for myself, and I'm going to give you a little bit because I want you to realize that brain and body do not work separately. Brain and body work together. And saying that, I was also having my own personal role conflict. I'm a wife, but also I'm a nurse. That can be good and that can be bad, because as a nurse, I saw all the negative things that could happen. And I saw the diverse effects that, especially working in palliative care and oncology. I would have one patient that I would be for oncology, trying to give them the best results, you know, and to say, hey, you know, you can beat this, you can do this. And in the next bed, right beside each other, I had a palliative person who I was trying to give a very graceful and you know, end of life. And I think over a 2-year period, I saw 1 death per day. And coming from mother baby to seeing all this death, it almost put me into a post-traumatic stress kind of thing, like a survivor's guilt. And it was tough. It was tough. I got to be honest with you, it was really tough to see. I think I can remember one day where I had 1 bed in a 12-hour shift. I filled it 3 times because I had 2 deaths back to back. So that wears on you. So you bring this home with you at the end of the day. And that was my biggest fear, that I was going to lose my spouse. I was going to lose my partner. And of course, you know, no, you can't think that way. You've got to be optimistic, not pessimistic, and you've got to be there. Now, on the other breath, as a partner and a protector, that's where the nurse and the wife thing comes in again too. As a partner, I wanted to give him the say, hey, I'm there, I'm going to support you. And the protector says, oh no, you know, like you never get between a mother bear and her babies. Well, amplify that with a wife, a grandmother, a mother, and God help you. Do not get in between, because I want to make sure that my loved one is taken care of. And yes, that's maybe why I'm so very much an advocate for what I'm doing now, because I'm very passionate about what I do. And if I see someone that's in a situation where I see for some form of doom and gloom, or not, that's not quite right, where there might be potential harm come to that person, I will advocate for them for what they want. For, you know, and advocate for the fact that I'm an informed consent. I believe that's very important. and I'll relate another really quick story here with you. Before I left the palliative care unit, I had one patient who was stage 4 prostate cancer. He was my patient. The doc had come in and he was changing his catheter. Now, I know catheter, and only a urologist can touch a catheter for a fellow who's, in with prostate cancer or after prostatectomy. And the doctor did this without any form of analgesia. He did it. He just came in. He was sitting there. He was yoinking at the catheter. And in the same breath, I'm holding this poor man's hand, and he's crying out in pain. And that from that day forward, I said, no damn way am I going to let another man suffer like that from another person's hands. So that's another reason why I'm so passionate about prostate cancer and where I go from here. So that was a little bit of my mind game for you. I just want to make sure I've got all my notes here. I've covered that. Okay, I'm going to go forward. Now, are any of you familiar with Monty Python? Any of you? And the Holy Grail?
Yep.
Yeah, yep, there you go. You can open it up and tell me, are you familiar with the Holy Grail? Do you actually get a little bit of a chuckle from it and that? Excellent. Yes. And Boyd and I are, they've got that really dark humor. But do you know the Black Knight, the story behind the Black Knight? He's in, yes, exactly. And when I worked with Men's Health, oh crap, my thing keeps moving here.
Maybe Lorrie, you should tell everybody what it is, because I've seen the movie, but I don't know the
story.
Just quickly, maybe fill people in on the Black Knight.
Oh yeah, no, I will. My notes kept skipping on me here, John. Thank you. Anyhow, the Black Knight, he is, of course, the Dark Knight. He's in the middle of the forest, and King Arthur comes trucking along, and of course they've got the if you know about the coconut shells, and of course their budget was very low, so they're trotting through and their coconut shells are going, and they come across this Black Knight, and he's protecting just an itty bitty bridge. And of course, as the Black Knight approaches him, of course he starts, and if you see the little meme there, he starts hacking off limbs and things, and this poor man is just down to his head and his torso. Everything's gone. And as with men, and I'm also going to use women with this too in a minute, I don't know if it's a fact that I know with my own husband, it's a fact that no, I'm going to deny that I'm in pain. I'm going to deny the fact that it's even happening. Out of sight, out of mind type of thing. And this Black Knight, he is just very persistent. He keeps saying, nope. I'm come back here, you, and it's just a draw, Well, when I dealt with a lot of patients on palliative care, and with every breath and morsel, they wanted to, I think it's the survival instinct. And they just thought, well, nope, this is it. I'm going to meet my maker soon, and no matter what happens, I'm going to hang on here. I've got to click my notes here. No matter what happens, men are also taught that men don't cry. Men don't have emotion. We got to remain strong and stoic. And I know as myself as a nurse, when I came across so much death in that, we had to put up like a barrier, and we had to say to ourselves, no, we can't show an emotion, which is full of baloney, because as a nurse, it does wear on you. And like my story before, it does wear on you. So we all know, and we have more insight now in regards to mental health to say it's okay to have emotion. It's okay, but have that emotion in a place where you feel safe and secure. And that's why support groups are so important. And that's why this group is so very important. And that's where I feel, hang on here. Okay, all right. And that's where I feel is important. I'm just going to go on to the next slide here. And this is another one to kind of show walking in another person's shoes, and it shows empathy. And I'm just going to play this really quick. There we go. There we go. Now, showing that video, I find, oops, hang on. I find I use that video uh, when I taught the nurses, and I use that to show that we have to be aware of others, and that's the same with prostate cancer. That's the same as me saying, well, you fellows know what it's like to have a baby. Well, that's the same for me to say, I don't know what it's like to have a prostate. So it's just walking in the other person's shoes and being aware of where we're at in our own journey. Now, I want to go on to the next portion, and this is where I wanted to discuss the process to diagnose and confirm prostate cancer. And before I get going here, do any of you have questions in regards to what we just discussed? No? Okay. Now, the process, this is just very general, but I know everyone's probably quite familiar with when we say PSA. And we all know it's a blood test, and it's used to screen the protein in the blood for the prostate. And we know it's just one of the tests that we do to confirm. But I always call this a speedometer. It's something to kind of show us like where we're going at. It's another gauge. Now there's another treatment, and it's a relatively new one. It's a PSMA PET scan, and I know in Quebec you have one of these scans now. Is it in Quebec City, if I remember correctly, John? I believe it is. It's in Quebec.
I think it was at one time, but no, there's a couple of places here. I think the Jewish and the Glen, both hospitals have those. Neil, you would maybe know. Neil is, I don't know where Neil is. Maybe he's working. He's
Okay.
working tonight. So, but I think there's two in town.
Yeah.
It's fairly new. I heard somebody say that the other day that they had to pay for this
Oh,
procedure.
really? Yes, they do.
But it's not always that you're having to pay in Quebec.
Yeah.
Generally not, I would say.
I know we had a fellow in Regina that went to Quebec City for a PSMA, and he had to pay for it. So, but it was what they use a PSMA PET scan is it's the radiation, or the type of radiation that they give you, binds onto the surface or binds to the protein that's on the surface of the prostate cancer cells. And then it's a tomography. It's a big fancy, I've never seen one, but it's a big fancy, like a CAT scan or an MRI. It's similar, but yet it's unto itself. Of course, the dreaded DRE, or the digital rectal exam, and I don't have to say anything more about that. We, even as a woman, we have to go through that as well. And of course, when they do check the prostate, they're looking for the prostate, and they'll determine any form of growth or anything or enlargement of the prostate. Biopsy, and of course, with a biopsy, and there's a couple of different ways in how they do biopsies now. Of course, the small hollow needle core samples and removed, and I'll discuss that throughout the my presentation as well. I know Boyd always reckons it to like how does he put it? Like almost like an arrow being shot, and I'm just thinking, oh, that sounds rather silly, but that's what he mainly remembers when he had his biopsies. Okay, now this is an old slide. It's from 2013, but I want you to be aware that this has since changed. And the reason is because in 2008 to 2012, the United States Task Force for Prevention had determined that they felt men were being overdiagnosed, and that they were doing a whole population PSA testing. Now they've determined in 2021 that because they had cut back on the testing, that they're now seeing more advanced forms of cancer. So because of that, the preventative task force has changed their tune and said, okay, yeah, we've got to continue with the PSA testing. That's very important. It helps us kind of gauge, and it's like our gas gauge or whatever. It helps us gauge. But there's a number of things that they have to be aware of with the PSA testing. That's why they're recommending now having centers of excellence that can help a man walk through the process. And that's something that we're looking at here in Saskatchewan. What we call it is the prostate assessment pathway, and it's a clinic in Saskatoon. They're very well established. In Regina, we're still building upon it, but it's a clinic where they kind of help the man walk through the process, and they found that it's very, very beneficial for the man to have a more of an informed consent when it comes to any form of prostate cancer. All right, now this is a PSMA PET scan, and I want you to be aware of this is the prostate right here. Now, I don't know what's happened to this man's other hip or anything. God help us, I don't know what happened there, but this is the prostate and of course the bladder. So it kind of gives you an idea of what they're looking at, and that's where it's all glowing. It's like a little night light there. Now, a prostate biopsy, and my poor husband just cringes with this. With the prostate biopsy, now they do 2 forms of prostate, and they found in Europe, I believe it's one of the Scandinavian countries where they're really pushing it, was that they're going up through the perineum. And I'll show you another picture of what I mean by the perineum. It's the area between the scrotum and the anus, and there's an area in there, and there's a very slight little area that they have to connect with to get that, other than going up the rectum. And when they go up the rectum, they have had more chances of infection and going septic, which puts you at greater risk for a lot of things as well. Okay, Gleason scale. Everyone is familiar with, and I always have to have a small chuckle with myself because whenever I go to our support groups and stuff, because I'm one of the facilitators, the men are all, they know their stuff. They're right on the mark there, and their Gleason scale and all that, and and then some of them like, well, what are you talking about? Please explain this to me. And I'm going to ask anyone right now, does anyone have a question in regards to the Gleason scale? See if I can answer it. Are you fairly familiar? You should be, because yeah. Okay, with this Gleason scale, you notice they have the 1, 2, 3, 4, and 5. And over here, when they do the biopsies, of course, there we go. I've got my little prostate here. When they do their biopsies, of course, they're going into, the bladder sits up in here. When they do the biopsies, of course, they take the portion, and wherever they're taking their portion, I think they take 12 core samples. And when they take the samples, then they grade it. And that's what they do. They'll say, like, if I have a 3 on this side and a 3 on this side, it's a 6. If I have a 4 on this side or a 3 on this side, 4 plus 6. So then they start grading it. Now, if you notice here, it says a 1 is a small uniform gland, and then it goes up to a 2. There's more space between the glands, and more marginal, more cells, and of course the dreaded 5, where there's lack of sheets of glands. Okay, now I want you to be aware, and I know John said it very nicely at the beginning, that treatment options do vary from man to man, but it's always got to be discussed with your physician. Nurses are trained to teach and educate, and we're also taught, and as part of our ethics, to make sure that patients have a well-informed consent. And they're informed. And if they aren't, then sometimes we drag a doctor back into the room and say, no, you continue and you finish talking with this person. You can finish off your education portion. And I've personally done that because I'm pretty strong for that. So as I mentioned, treatment options vary from person to person. It is now when I mentioned the PSA, now remember your PSA trends, and I'm going to use my husband again as an example. When he had his PSAs, his first one was a 6.4. His second, a couple of months later, was a 6.2. And just before he had his surgery, this was in May, and he had his surgery in November, it jumped to a 12.5. So we know that as the doubling factor. But what we didn't realize that the doctors had said that his Gleason scale had gone from like a 6, and they jumped it up to an 8 right away. And after he had his surgery, we also found out that he had very aggressive cancer, but it was well encapsulated. So we're very lucky. So that's in regards. So, but I also want you to be aware that the diagnostic test results, you have to look at all the tests. You have to look at everything as a package. It also depends upon the treatment options, like the level and what you have available in your area. In some rural areas, they send people off to like bigger centers. I know in Saskatchewan they do. I'm uncertain about Quebec. And you also have to look at your standards of care and your quality and quantity of life. That's always got to be taken into consideration. And I know the older you get and when you're diagnosed, they're always looking at your quality of life. Another avenue for treatment is your active surveillance. They used to call it watchful waiting, but we know active surveillance, they closely watch your PSAs. I've had one fellow lately just go into active surveillance, but they didn't do a biopsy. I thought, oh, okay, I thought that was part and parcel, but I guess not necessarily so. And he chose just to be on active surveillance by watching his PSAs. A prostatectomy, and I know some of you identified that you had prostatectomies. We have an open resection, of course, where they open you right up, be it abdomen. Sometimes they'll do it perineal or through that area between the scrotum and the anus, laparoscopically or robotic. Radiation, and some of you identified the different forms of radiation. The brachytherapy, an internal or an external beam, or high dose or low dose. So that all varies in the area and what you have available again. ADT. Now we also know for some people that have had prostatectomies, depend upon how, like if they had good margins or how successful it was, they may have salvage radiation, which means they'll have it in combination of radiation plus the ADT. Chemotherapy, that is the one that always gives people the chills when they hear chemotherapy, because there's, oh my God, there's horrible side effects with that. It just depends upon the type of cancer, of course. It depends upon the person. And when I worked on oncology, we had to gown, mask, glove. We had a whole protocol because some of the medications we had to give were very toxic and very potent. But that is only in certain cases, not necessarily so for prostate cancer. Immunotherapy, I just worked a little bit with that. And HIFU, I'm not really well in tune with, but this is one of the newer ones that I understand. That's ultrasound and cryosurgery, where they freeze the cancer or the prostate, pardon me. Radical, I kind of went through that quickly. Removes the whole gland, the seminal, perineal, testicles, and the anus. Laparoscopically, that is, of course, it's a camera, goes through the abdomen. They have maybe 5 or 6 small incisions throughout the abdomen. It's a lighted, guided, a guided camera. Robotic is totally through the robotic and the laparoscopically. And a TURP, which is a transurethral resection of the prostate. They will use this for more benign prostates, where the prostate is more enlarged. But I have in the back in like when my dad was younger and my husband's dad was younger, they had TERPs because they had problems passing their urine. But we also think that they had some form of cancer, and they chose to have a TERP as opposed to just so that they could have improved quality of life. Now, if I remember correctly, I've got female and male here. That's just the way the slide showed up. But this is that area I was telling you about, the perineal area, and with the prostate gland and through here. And it's between the scrotum and here, but there's a very thin little area where they look, and but they have found that great improvements in regards to biopsies with that. So that's one excellent slide. Also, I wanted to show, I have my little prostate here. I wanted to show how the significance, of course, that is the penis and the urethra, and the prostate itself here. And look at all the nerve endings. And when they say, well, why am I having so many problems with urinary continence or ED? Because of the nerve endings. And that's part and parcel of why that doesn't want to work anymore. Here again is the seminal vesicles. I have to look at this, the prostate itself, and of course all the other little, I think I'm trying to see where their nerves are here. I don't have my glasses on here, so I apologize. But this gives an excellent view of the nerves in through here. All right, now, I love these two pictures because this kind of goes hand in hand with the TERP and how it shows a benign prostate and where it's enlarged. You see here, it's the urethra and where it's all closed off. So when they do a TERP, they just go through, they go into into the prostate gland and just scrape away and just make it a little bit easier for you to pass your water. Here is a normal prostate and of course an enlarged prostate. I've also put alongside that, and did any of you know that you had a man has two sphincters, bladder sphincters? Were you aware of that? Anyone? Yeah. A woman only has one. You guys came up with two. So you have one that's right at the neck of the bladder, right in through here. And then you have another one right in the pelvic floor. And of course, here's your prostate. Now remember, when they do a prostatectomy, they will remove the prostate and then they're taking out a portion of that urethra as well. But look down here, why it's so very important to have your, that's your pelvic floor muscles, and why it's so very important to have those muscles in good shape. And I'll continue here with that. Okay. Have any of you had a catheter, a Foley catheter? Uh-huh. Yeah. Do you have good memories or bad memories, Clifford? Je ne sais pas. Yeah. Well, this is a Foley catheter. There's many different kinds of catheters out there. And this one is, if you notice, this is a size 16 or whatever, but that just means the gauge of the catheter. Now, in this part, what keeps the catheter in place in your bladder is they have a balloon, and this balloon right in through here has 10 mils of water. So God help you if you try yoinking that out, because it's going to hurt like heck. And when Boyd had his catheter in place, of course, he was testing me to see if I was actually listening to him. And he said, hey, honey, I'm just going through the instructions here for the catheter care. It just says, yeah, just pull on that catheter. And if it doesn't come, just pull a little harder. And I all but jumped out of my skin and yelling at him, what the heck is wrong with you? You're not going to yoink that out. No, dear God, do not yoink that out with that balloon, because God help you, it's going to hurt like heck and you're not going to like it. So there you go. Catheter care also, another thing that I popped in here was your urinary bladder bag. And now Clifford, do you remember having the bladder bags and the leg bags as well? Just the leg bag?
Cliff, you're muted. You're muted, Cliff.
Yeah.
Thank you. Yeah, no, it was after brachytherapy, and I was still under the effects of the
Drugs.
drug. So by
Yeah.
the time I woke up, it was still there, but it wasn't for very long.
Okay, well then you're lucky because I think Boyd had his for like 10 days or something.
Oh, no. I'm
Yeah.
sure there's other people. There are other people in the group.
Oh yeah. Well, if it happens that they need to insert a catheter or anything into you now, I believe you still need a urologist to do it after prostatectomy and certain treatments. At least I would ask for one. I wouldn't just have anyone, insert a catheter. But this bedside bag, that's one of the units that you use for nighttime, and of course it holds. Oh, I think it holds up to like 2 liters of urine. Your leg bag, of course, just goes on the side of your leg. That holds approximately, oh, I've seen some people fill at least a whole liter into that, but it's bulging and not highly recommended because it can leak, but and changing it frequently. And when you do have catheter, you have to have meticulous catheter care, which means you have to make sure everything's clean. Of course, after surgery or any form of treatment, you have to make sure that around the glands of the penis is well clean. And they'll teach you before, well, they should teach you before you leave hospital, or if you have a catheter in place, and they should teach you the aftercare with that as well. Does anyone have questions in regards to that for me? No?
Just I was treated at the Jewish. I had a prostatectomy, and then I had the leg bag catheter in for about a week. I think it was a week. It was fairly standard practice, I think.
Mm-hmm.
But then I was fine. I went home, and then I developed an infection in my bladder or somewhere in that area.
Mm-hmm.
And I couldn't pee. I was in the emergency ward twice.
Mhm.
And eventually that was cleared up with, I guess, the antibiotics.
Yep.
But
Yep.
it was kind of weird because you were I was at the Jewish in the emergency ward, and they wanted to get a urine sample. And it was really difficult. Like, eventually I was able to give them a few grams so they could do a test on it.
Mhm.
So,
Yep. And did it? I guarantee it came back growing something.
oh
But
yeah,
yeah,
I had to go on antibiotics. Yeah.
yeah. Well, you're lucky because we had a fellow here, John, that actually he went septic. And he was in
Oh, wow.
hospital for a month. Yeah. So yeah, you're very lucky. But meticulous bladder care, and that's very, very important. And before anyone leaves the hospital, if they're leaving the hospital with a catheter, you demand that they give you some form of teaching. And if you don't feel comfortable with that, you demand that, okay, like, I don't feel comfortable removing it. Who's going to remove it? So that's my say. Please, dear God, don't go and yoink it out, like my husband was trying to tease me with on your own with a full 10 mil ball.
Hmm.
Oh, gosh.
Interesting. When I had it taken out, there was a male nurse at the Jewish that took it out. He was, I guess, authorized to do it.
Yeah. Oh, but then you're lucky. Yeah. Yeah, because like for nurses and stuff, you have to have levels of certification.
Yeah.
And yeah, and it's very important. Okay, well, thank you for sharing, John.
Hi, it's Andrew. Hi.
Pardon?
Hi, it's Andrew. Can you hear me?
I can hear you. I'm just trying
Yeah.
to see your face here, Andrew.
I think I'm on video.
Oh, well, hang on. Oh, I got to look for you. All right.
Hello.
No, go ahead and keep talking. I'm listening.
Yeah. So I'm just gonna briefly say, like John, I had a prostatectomy, and I had the catheter, the leg one, and the night bag. I had it for a week, and luckily I had no infections, no problems. And at my local CLSC, I'm not sure you have CLCs in Regina, but the CLC nurse took it out at the end of 7 days. So it was removed by a nurse at CLSC.
Yeah, and I know here, like Boyd was lucky he had me at home. But we do send our fellows here to like a home care clinic and that, and to have it removed. Or if there's someone that's, you know, had some difficulty, they'll go back to the urologist. Yeah. Thank you for sharing, Andrew. And I'm going to just pop this in here. Blood, yeah, I know post-operatively or post-treatment is normal. As long as it's decreasing and it's not increasing, it's not fresh, it should look like a raspberry tea kind of color, but it will subside over time. If it doesn't subside, then I would be concerned. Sometimes I've seen actual chunks of blood clots in that. And yeah, I wouldn't be too concerned, but if it's fresh bleeding, yes, I would be concerned. But it is normal to see some form of blood in the urine, especially post-operative.
Neil here. I'm going to chime in. So
Yes.
my urologist said that you could have like blood clots for up to about 6 months, and I actually did have a few blood clots at around 3 months, and about 6 months I had a couple of big ones finally came loose.
Yeah. Did you have? I'm going to ask you: was your surgery fairly close to the neck of the bladder? Because it sounded like it was fairly invasive.
Well, it was the robotic prostatectomy.
Ah, okay.
And so that was, so when you have that, there you're definitely going to get some residue. Some
It
debris.
almost sounds like there's a little bit more irritation. They want to go up into the bladder more or something like. But you know,
Well, it's yes, there is some, because also when they're resecting the prostate, they irritate everything, which he didn't
Yes.
tell me beforehand.
Yeah.
But I found it the hard way afterwards.
Oh,
That
definitely.
he has to resect the prostate because it's actually attached to your rectum and to your bladder.
Yep.
And so when they remove it, they irritate, everything gets inflamed.
Yep.
And so there is some inflammation. You can get blood clots, like you say. Plus, just from the surgery where they're reattaching the urethra back to the bladder, you're going to
Yes.
have right there. You're going to have also. So
Yep.
I was
Yep.
surprised actually to get 6 months. I actually had quite a large piece.
Oh, gracious. You know, that's a long time. But, you know, like here in Saskatchewan, we don't have the robotic surgery yet. We have the laparoscopic, but we don't have the robotic. So thank you for sharing, because that's a piece of learning for me as well, Neil.
Yeah,
Thank you.
you know, I heard Ontario wants to actually. They were talking about eliminating the robotic because it costs the government more,
Yep.
and they don't find that there's that much of a benefit over the full radical.
Yeah. Yeah. Well, again, Boyd was lucky when he went up to Saskatoon. He had a surgery in Saskatoon, and he had a doctor that specialized in the least invasive radical prostatectomy via laparoscopy, and he was very lucky. You know, he really was. We like I said, we count our blessings. We really do. Okay, now I gotta find my thing here. So, like I said about now that is a different type of bed bag, but I wanted you to be aware that, you know, you might see some blood. Now, I'm going to, I didn't put a slide in here, but I want to briefly talk about bowel care too. And I don't know why this totally slipped my mind when I made this presentation, but bowel care is also very important. And I wanted to touch on that before, like with the pelvic, before I got to the pelvic floor part, is you do not want a lot of straining. And the reason for that is because, like Neil had mentioned, your prostate is attached to the bladder as well as to the bowel. So you don't want a lot of extra straining. You want that area to heal nicely. You don't want any herniations. You don't want any bleeding, any further inflammation. And of course, if you have to strain to have a bowel movement, you know, inevitably, you know, is something's going to happen. And I've had some of our fellows here in Regina complain of severe constipation after. And that this is why it's so very important to make sure you have a you know, a stool softener, some form of a bowel care. You know, if you're lucky to have a bowel movement while you're in hospital, if you've had the treatment, or after prostatectomy to have that bowel movement, but they should give you some form of bowel care and stool softeners, and increase your diet in regards to increased fiber and things like that. Now, another piece I wanted to talk about here before I go on from this is the fact of your bladder. And if with some after a prostatectomy, of course, you're going to notice a more urinary leakage if you may drink more caffeine, if you drink maybe pop drinks, if you drink more acidic drinks. And what's really interesting is with Boyd, he can drink coffee till it comes out of his ear balls, but he can't have anything acidic like orange juice or anything. That really bothers him. Orange juice, but he can eat oranges. So it's interesting. You have to kind of weigh that yourself and see what works for you and what doesn't. Because you'll notice if you have something that irritates the bladder, it will increase your urinary incontinence. So just be aware for yourself as well. Now, I'm going to go on to the pelvic floor and why is it so important for the physiotherapy? Now, I'm uncertain. In Quebec, do you have pre and post pelvic floor physiotherapy?
Yes, there's a clinic on the West Island of Montreal
Mm-hmm.
that they specialize in for both for men and for women,
Mm-hmm.
usually
But
pregnant women.
it's
and-
not
and
included
the-
though in any hospital care. It's something you have to seek out yourself.
Yeah. And like I mentioned here in Saskatchewan too, but in Saskatchewan, we have it paid for. In Saskatoon and Regina, our fellows have to pay for it out of pocket. And if you don't have any form of third person insurance, that can be a burden, or it can be a barrier for some people.
It's not paid here at all, as far as I'm aware.
Yeah. But it's one piece of the treatment that does help. And they've got studies where they said that they found that the pelvic floor physiotherapy is very effective after prostatectomies and prostate cancer. For other forms of cancer, they said not as effective, but they said prostate is very effective. And as I pointed out, if you look at this, I love this picture because it shows the pelvic floor and how, and of course, look right there, we've got the urethra, we've got that other sphincter. It's right in the mess of all of that pelvic floor. So it's it's a great little. And I often say some compare it to a Kegels, but not really, because I've heard some of our fellows complain of a lot of deep pelvic pain. And what has happened is sometimes they'll have nerve sparing, they'll have extra nerves down there, but they're tightening up their muscles far too much. And of course, it creates more pain. So when you go through with a physiotherapist, they will walk you through the proper process on how to do your Kegels and how to strengthen up those muscles.
This is Eric. My urologist kind of characterized it as holding one of those very thin plastic beer cups.
Yes.
In the level of pressure you put on
Yeah.
is not, you don't want to collapse the cup, but you want to hold it firmly enough that it's held.
Yeah.
And unfortunately, I think I had training before the surgery. I didn't do anything after. I strongly suspect I was too aggressive with doing any kind of pelvic tightening, and I may have actually created problems. So you have to be careful with that after the surgery.
And that's why I see Boyd, my husband, Boyd was in the same boat. He had the pre-treatment or the pre-physiotherapy where they talked about the pelvic floor therapy. And after he went back and did his physiotherapy as well. And they kind of helped. And he said it actually really did help with his urinary incontinence. And I think he's down to maybe just dribbles and just the small little pee pads, which is excellent, which is really excellent. Thank you for sharing, Eric.
I have a question regarding that. I'm scheduled to have surgery in sometime between 3 and 6 months. That's how long the waiting list is in Ottawa right now. Is there any benefit in my doing pelvic floor exercises now while I'm waiting for the surgery to strengthen those muscles?
You know, I would say go and see a physiotherapist and see what they recommend, and they can kind of help you walk through it as well. Now, I'm sorry, I'm trying to find your
Mike.
name here.
Mike Nielsen. Yeah.
Yeah.
Okay, I'll do that. Thank you.
Yeah, and actually, Mike, yeah, it doesn't hurt because I know Boyd had his, and it's just as I think they'll tell you a week before they don't want you doing too much of the pelvic floor exercises, but you're well on your way, and they'll help. I think it's more beneficial after because they'll help teach you how to tighten it, but not tighten it where you crush that beer glass. Okay.
Okay. Yeah.
So it's very, in Boyd's case, it works wonderfully. And actually, it does help with some of the ED as well. So, yeah, you know that you got to exercise those muscles.
Okay. Yeah.
Okay.
Can I ask a question?
Yes. And
Excuse me.
who am I talking to?
It's Murray.
Okay.
I'm probably going to have radiation therapy.
Mm-hmm.
It'll start near the middle of the summer.
Mm-hmm.
I'm curious to know, how does it affect the external and internal sphincter muscles,
Well,
as opposed to when you have radical prostatectomy,
mm-hmm.
which affects the sphincter muscles. I think it's probably the one on below the bladder.
Now I've heard I've heard two schools of thought with that, Murray. And one school of thought is, with some fellows, they don't see anything until later on. When I say later on, sometimes I've heard some up to a year after. Some may see it after 1 or 2. You may have a bit of burning on urination, but it depends upon yourself, really. It also depends upon the fact of, the dosage. It also depends upon the type of radiation, how invasive they have to get with the radiation. But I'm also going to recommend too that when you see your radiologist or your radiation oncologist, also ask him too. Put that in your list of questions and ask him, hey, this is my concern. What should I be watching out for? Should I be watching out for more concerns of my bladder and more irritation? And I find that works quite nicely. Did I
Okay.
answer your question? Okay. Yes, Michael.
Thank you.
I just want to say one thing. Everything you're saying is 100% correct. But
Yeah.
I just, from my own experience,
Mhm.
I can tell you, here in Quebec, and especially the radiology department and whatnot, they won't talk about pelvic floor physiotherapists. They won't even discuss all of this. And even when you talk about it and they tell you, oh, well, you just squeeze your muscles and do that there. And that's from my oncologist. Okay. And he's going, and I go, this is after I'd been to physio, which I found out through our group, because I had no idea that there were pelvic floor physiotherapists. That's all they do, right? I didn't know that, right? But having said that, even when those guys, they don't know anything. They don't care. They don't want to know about that. It's a shame, and they don't talk about that. And that's why groups like ours probably have more benefit from that type of a thing. And I can tell you, it's after having gone through it with and guys, is extremely intimate. I can only tell you that when they're training you. Having said that, though, it's quite an experience to learn how to do it properly.
Yes.
And Murray, radiation can have latent effects.
Yes.
Not only a year, 2 years later, 3 years later, things change because it affects it. Yeah. So it's all part of it. But they don't talk, at least here, my experience, they don't talk about this at all.
And Michael,
Shame.
and you've said that's excellent, Michael, because that's what happened here in Regina. They didn't say anything about physiotherapy. And in regard to pelvic floor. In fact, I was the one that was going for pelvic floor therapy after I had all my tumors removed out of my abdomen. And I was going for physiotherapy, and it was me that was asking my physiotherapist, would that be beneficial for my husband? She says, yes, it would. But you know what? It's not paid for here in Regina. It's paid for in so, and you know, and beneficial for me. So can you imagine for a male anatomy? Yeah.
Would
So,
it be okay?
Lori, can I break in there? Lori, it's Mo. Can I break in there for a second about terping?
Can I
sure,
please
go
ask
for
a
it.
question?
Okay, Lori, you were talking about terping before, and I must tell you that I have been using for a catheter now for 2.5 years, okay? But prior to the use of it, I messed it up. Instead of changing it every day, I was like going for 3 days with a catheter, and of course I was stuck in the hospital with an infection. Now I was very fortunate. My urologist turned me 3.5 years ago. And I'm using now, as of this moment I'm talking to you, I use 3, 4, and sometimes 5 catheters a day. And they're only like 10 cents a piece, so it's not a big deal. Yeah, okay. So and I am extremely careful. I'm going to tell you, I have been so careful. And every time I'm into one of these meetings, this is the first time I've really been able to talk about a terping. I've heard terping. I was turfed, and he told me, no, you're cancer free. Now get out of here. So I've been very fortunate, as I say, for at least 2.5, maybe 3 years. I've been using catheters. My daughter supplies me with catheters. She can get them wholesale. So I use 3, 4 a day. Okay, and I don't care about that. I'm very careful using it, and I do everything that I could possibly do to clean it. I've got the swabs would I clean that, and so I don't go anywhere within 3, 4 hours. I don't a bunch of catheters with me. So if I have to stop somewhere, I use them. So I want to thank you. So it's a terping thing, and I was very fortunate. My urologist, I talked to him about a year ago. I was having a small pain with my right testicle. So I went to see him. He says, what do you want here? He says, nothing wrong with your testicle. And he felt my testicle. Get out of here. So that's like 2 years in a row. He's told me to get out of his office. So as long as I'm using my turf, my catheters, I feel extremely grateful that I can at least use that. I'm not a young man anymore. I'm 91 years old, but I can still pee. So these catheters are just extremely, so I strongly recommend if anybody's listening to this or wants to contact you, you get these catheters and you just be very careful with them, make sure they're clean, et cetera, et cetera. So thank you for listening, and good luck to all of the people in the audience there. Thank you. My name is Mo, and I'm a terp. I'm a terp man. Goodbye.
You're a terp man, and actually, Mo, you make some good points, and with the catheter and that, and of course, that's because they can't, access the urethra is of course too restricted in that. Or yeah. So thank you for sharing, Mo. That was.
What do you mean by that? That's restrictive. I don't follow that.
Well, because with a TERP, when they do a TERP, it's because the prostate has really shrunk down the urethra. So
right.
I gathered you're going through the penis to catheterize yourself, correct?
Yes, I am. Yep.
Because there are suprapubic catheters as well. So yeah, no, it's because of the restriction and all the internal stuff.
All right, I have to, excuse me, guys.
Yeah.
I don't know how much more of your presentation you have, Lori, but we really should hold any more questions for the end, because otherwise we're not going to get through this, because we're supposed to end in 12 minutes.
Okay, sounds good. Okay, gentlemen, hang on to your pants. We're going to get through this. Okay, so as I mentioned, remember all those pelvic floor muscles. That's it in a nutshell. And that's a male anatomy. And there you go. Look, there's like, how many are there? And that goes to say you start, working on that, and that'll, it's very beneficial. Okay, now we talked about, as we've gone through the presentation, we have, of course, the different forms of radiation, of brachytherapy, and that. I'm not going to focus too much on this because we've talked about this. It's basically just be well aware of that. And it's really sad that you guys don't have like a nurse navigator kind of help you walk through this as well, because this is what I've kind of done with some of our fellows, is kind of help them walk through this process as well, and got them to our nurse navigators at our pelvic, at our prostate assessment clinics. But that's it in a nutshell. We kind of talked about that briefly. Here are, now remember we said about external beam, there's the prostate, and we've got the beams coming at it at different angles. And of course a prostate again, and they're really trying to focus, and you always hear different clinical studies. Here is again the brachytherapy, or an internal, and you can kind of see where they have some of the seeds in there in regards to the internal radiation. I'm going to go through, guys, and then we'll get through this. There's different forms of androgen deprivation. Of course, the surgical castration. As a female, I had that, like I had my hysterectomy and that was like now. There's the different antagonists, and somebody mentioned that they were on an LH, a medical ADT, the antagonist. I'm trying to think, it was, hang on, I'm trying to find it. Azole. What was it again? I can't remember which one it was. The Zoladex. Zoladex? Am I correct in saying that? And that's an antagonist. And non-steroidal. I'm going to focus on these ones at this point in time, but I'm going to go through, you guys. The one LH antagonist, and this one, what it does is the first one. Oh, sorry. This one is a slow, hang on here, decreases. Now, one of these slowly puts you into menopause, and the other one puts you through a radical menopause, or a radical sex or androgen. Now, this is one that is a rapid decrease, is the antagonist, and I've got a list of those as well. So that's basically your pituitary gland and different hormone levels, and it rapidly decreases it, whereas the antagonist, or the other one, is a slow decrease. Here are the different drugs, and I think the Zoladex, that was one that someone had mentioned, and these are the slow moving, or slow testosterone.
Slow release, isn't the term?
Thank you. I was searching for words, and this was the faster decrease in the hormones. Now, an anti-androgen. Now, this is a fairly new one that they're coming out with. What it does is that actually binds. Some of these are used for castrate-resistant cancers, and what this one does is it blocks the testosterone hormones for attaching within the cancer cells themselves. So this is fairly new. It's a new process. Please watch for this one in the future, fellows, because they're always doing some new things with this one. And these are some of the castrate-resistant medication that are out there. I believe this is one that I've heard of quite a bit here in Canada. Abatrone, I hope I pronounced that correctly. And I've heard quite a bit about that. I haven't had anyone that's been on it, but I've heard about it. How's that sound? Now, these are some of the other forms, and I'm not going to focus too much on these. The one is for like a benign prostate, or an enlarged prostate, and the other one is more of a non-steroidal anti-androgen. and they've got the Gleason score there, what they usually focus on. All right. Do we have time for this video, or do you want to talk more, fellows?
How long is the video?
It's about 4 minutes.
Okay, you can play it.
Okay, sounds good. Okay, now be prepared before this video, and I'm going to give you a short lead up. Boyd and I, like I said, we're very much, we do things together, and part of our first experience with my husband, and I've got his permission to share this, is that we use the trimix, or an injection, to help with the erections. And when he was the second time he's using trying to inject himself, and he was trying to inject on his weak side. Now, if you notice the term, we've got a bleeder. I'll let the video, and then we will discuss it after. Okay.
Okay, kid, listen, I'm coming in, okay? No, don't. Exactly what the hell is the situation? What, did you shit yourself or something? Oh, I wish. I got it stuck. You got what stuck? It. Oh! Well, listen, it's not the end of the world. These kind of things happen. Let's have a look at it. No, for God, never say Sheila. No. Sheila, honey. Don't. Sheila, honey, you gotta come here. You gotta see this.
What? No.
Don't come in here, honey. Don't. Don't worry. She's a dental hygienist. She'll know exactly what to do.
Hi, Ted.
Hi, Mrs. Jensen. How are you?
You okay?
Yeah.
Holy shit! Charlie, you could have warned me. Keep it down. Okay,
Sorry, Mrs. Jensen. I just don't want her. I don't want her here. You know.
Let's just relax here, okay? Now, what exactly are we looking at here?
What do you mean? What?
Well, I mean, is it the what the?
Is it the Franco the beans? I don't know. It looks like I think it's a little bit of both.
Break some veins! Break some veins!
What's that bubble there? What do you think? It's a. Well, how the hell did you get the beans above the Frank? I mean, I don't know. It wasn't like it was a well thought out plan.
You know, there really does seem to be an awful lot of skin coming through there. So I'm gonna find some Bactine, honey.
No, you know what? I don't need any. Really.
Oh, there.
Oh, Christ.
What the hell's going on here? Neighbors said they heard a lady scream.
Well, you're looking at him. You gotta take a look at this thing.
Oh, Jesus.
Ain't it a beaut?
What the hell were you thinking? How the hell did you get the zipper all the way to the top?
Well, let's just say the kid's limber.
Ow! Ow! Christ! What the?
Somebody's gonna have to move that station wagon to the front so I can get the truck in here.
Lenny, come here.
Oh.
Take a look at what this numbnuts did.
Holy shit! Mike, Eddie, get down here quick. Bring everybody. Bring a camera. You're not gonna believe this. We got a kid down here. What's your name?
No, there's only one thing to do here.
Wait, you know what? I got an idea. Look. We don't have to do anything because, look, I can just wear this over the front. Look, I can go to the prom. We'll deal with it later. Relax. You already laid the tracks. That's the hard part. Now we're just going to back it up.
Teddy, be brave.
It's just like pulling off a Band-Aid. A 1 and 2 and
We got a bleeder!
Okay, so I'm sorry, fellows, but I felt that was something that Boyd and I wanted to share with everyone, and just for the simple reason is now you can kind of let your imagination wander with you. And when Boyd was trying with his weak side to give himself the injection, and I said, no, honey, I'll come in, I'll help you, I'll be that nurse, I'll get in there. I took the needle and I went in there and I took it out, and of course I had a bleeder all over the place. And yes, but Boyd and I now can laugh about it. We were, mind you, I was laughing at the time, but I shouldn't have been. But you know, it is something that, you know, we need to have a bit of a chuckle, and we allow you to have a chuckle with us. So I had to share that. Now, are there any questions for me, fellows?
Could we get away from the share? Could we go
Yep.
change
There
the
we
screen?
go.
That's what I want to do. Yeah.
There we
Good.
go.
Good. Good.
Thank you.
I'm
we've
going to stop
covered-
the recording now.
Yes, thank you.
We've covered quite a lot tonight.